So it's the top of the hour. We'll get started. I'm Thea Waguespack in Houston, and I'd like to welcome you to today's GlomCon seminar. Today, our talk is titled Organized Deposits, Differential, Diagnosis and Histopathology. We're excited to welcome our speaker, Dr. Amanda Tchakarov.
Thank you, Dia, for that introduction. Let me share my screen. Okay, so you all should be able to see my screen now, and I am going to be discussing pathology, and so I will be pointing out several things using my mouse pointer, so hopefully you all will be able to follow along and see that there. So thank you again for having me. I'm Amanda Tchakarov. I am the Director of Renal Pathology over here at McGovern Medical School. So I am going to try to make this a little bit interactive. So I do have a few questions for Pull Everywhere. So if you're able to scan the QR code, and then we can try to get a little bit of audience participation during the lecture to make it a little bit more interactive. So the objectives, I'm going to be discussing organized deposits within glomerular nephropathy. So and by the end, hopefully, we will be able to describe the pathologic findings of amyloidosis, fibrillary GN, how they vary, as well as the findings of cryoglobulins and the findings in immunotactoid. So this is going to be a case-based presentation of glomerulopathies with organized deposits. It's going to be touching a little bit on the pathogenesis, but it's going to be primarily focusing on the pathologic presentation and the different variations of these processes. And it's not going to cover all glomerulopathies with organized deposits because that would take probably far more than the hour that we have. So going into our first case, this is a 70-year-old female with a history of alcoholic cirrhosis, diabetes, and increasing creatinine. Her workup showed a decreased C3 and otherwise was within normal limits. So when looking at kidney biopsies, I like to start with a trichrome stain on low power to kind of get an idea of is this a more acute or a chronic type process. Looking at her biopsy, we can see that there is a little bit of interstitial fibrosis with tubular atrophy, but overall there's not a ton of chronic change, just a little bit of mild chronic changes. Looking at high power on the glomeruli, we can appreciate that there is a little bit of mesangial matrix expansion, fairly mild, as well as perhaps a little bit of mesangial hypercellularity. And we do see some areas that are suggestive of a little bit of segmental endocapillary hypercellularity, again, very subtle in appearance. Looking at PAS stain, that can help us appreciate that there is a little bit of mesangial matrix expansion, as well as a little bit of mild mesangial hypercellularity there. And if we look at the interstitium, there does appear to be some areas where there might be a little bit of interstitial matrix expansion, but it is overall fairly subtle changes. Looking at immunofluorescence, we can see that within the glomeruli, IgA does have significant mesangial granular deposits, where IgG and IgM are negative, and C3 also has similar deposits. Looking at kappa and lambda, they have similar deposits as what we saw with the IgA, and C1q was negative. So this is our first Pull Everywhere question. Again, if you didn't get a chance to scan the QR code, we do have it here. But based off of these findings, what is the most likely diagnosis in this kidney? So I'll give you all a few minutes to, or not a few minutes, a few seconds to weigh in as far as that goes. So looking over at the responses, yes. So based off of what we've seen so far, IgA nephropathy does seem like the most likely diagnosis. However, there is also the option that there may be more one of the above here, particularly given the topic of the lecture. So in addition to our routine immunofluorescence panel, for any patient above the age of 50 in our laboratory, we do a thioflavin T stain. So in this particular patient, the thioflavin T stain was actually positive. So now we can begin to see that there are some interstitial deposits along here and along here as well as the